And third rule, we understand that nurses are social beings, and we have been denied to move from one county to another. I don't know if you had time also to look onto that in relation to maybe inefficiency or motivational factors. We have ailing nurses who are supposed to join their families, but because they were devolved from the national in different counties, they cannot be with their families maybe to take care of their ailing parents or spouses. Thank you.
Thank you. The last one.
Especially when you mentioned about clearing these ghost workers, because you can imagine in some areas you find that a small maybe dispensary has maybe a nurse or two, and if one is sick, you find that maybe at times the dispensary is closed. So if you find counties whereby the number of ghost workers are existing and such a big number, it is really, really worrying, because the money is being wasted, as you say, can be used to recruit more nurses. So my question is, when you visit such counties whereby you get resistance, do you just sit back, or are there other avenues you can explore so that at least you can bring some sanity into that such counties as a ministry? Thank you.
Thank you, Dr. for that presentation. I just want to know, you talked about specialization, and I look at it at two levels. Specialization at what level in nursing, but then my concern is, as part of what you're calling inefficiency and people not being motivated, coming from a training school, you find that people are being trained at the higher national diplomas. I don't know if you featured them in your presentation, and yet when they go back, they are not really considered specialized because of what specialization actually means, but they offer a service that is not recognized even in the schemes of service. So that would again negate the idea of trying to take someone specialized to the level where they need to give the service. Thank you.
It's good to note that there is demand even to various levels of nursing practice. Now, the issue of enrolled level, mine is not really a question, but just a remark to put into place what is there. Actually, in nursing, we were thinking that we can start our entry point at a very higher level, and that one is with the Nursing Council, the Ministry, and KMTC, when we started from the KRCHN basic. But from needs assessment, it was realized that the enrolled level is still required in some parts of our country, where even with the affirmative action, they could not get enough qualified candidates for the registered level. And that one gave us a leeway to continue with the enrolled training. And they are doing a lot of work in those areas, because now in MTC in Mandera, Wajir, and Athi River, we are able to get students to enter into the courses. And the issue of restriction across the county lines is to make sure that those people who train in those areas are able to offer services in those areas so that we can improve the staffing in our health system. From Kenya Medical Training College, we train more than about 70% of the nurses, because we have increased the schools and we are now at 65 campuses in the whole country, and we are going to 68 very soon. Now, we have diversified training to include the nurses who are going to be responsive for the universal health care. And we have got family health nursing training, which has been started, and it is continuing. With that, and the community health nurses at the community will be able to give a good backup to the workforce, so that we deal with the wellness and not only the illness, and that is very, very important. So those ones who are interested, the environment is there for learning, the course is there. We are also looking at a situation where the employers are not able to release the nurses for in-service courses, and we are developing the e-learning and the distant learning to be able to impart knowledge as well as one is working. So we are on the move, and we have to continue as nurses. Thank you.
incentives. You've talked about appreciation of nurses. You come to realize that in our places of work, nurses are doing good job, especially in research, in practice, but you realize that it is becoming hard for the upcoming nurses to be able to continue with the good work that they are doing. You will find that the managers or the people who are really leading the nurses are coming to a point of not recognizing the good work. Is there a way that can be done universally? For example, now here we are for ECSACON, which is covering the East, Central, and Southern Africa. Is there anything that can be done to make sure that those upcoming nurses can be appreciated, can be recognized, and the good work continues?
Colleague Dr. Soti to address some of them. And specifically, Dr. Soti, the last question, and also about the ailing. So just prepare for that. Now, and then you can also add anything else. Now, the first one is in terms of the shortage of the nurses. What are we actually doing? Now, several solutions. One, make best use of what we have. And this is through upgrades that we can actually do, strengthen the skills and competencies. Now, currently, we are working with this WHO is in study, and what we are doing is to provide information to the ministry in terms of the workload, to bring up the information that the health workforce that we have are overworked. And the proposals is that you still have sufficient health workforce if we had a balance in terms of deployment redistribution. So that is what we are actually doing at the moment. And I know the ministry is also working to, the ministry also has a projection in terms of increasing the health workforce. But the challenge, as in any other place, is in terms of the finances. So there are certain things that we can do for now, but the other one is to give an opportunity for the ministry also to be able to assist. And in this case, I'm talking both of the county and also the national ministry. And we are actually going to face even a bigger problem in this country. As you know, this country has actually moved to a middle income country. And what is happening? It is good for us to say that we have grown to be middle income. But the other side effect is that the donors who have actually been supporting us are saying now, we have supported you to work. So what we want you to do now is to do what? Is to work. So most of the donors are now expecting the government to take on the payroll of those people who were previously supported by USAID, DFID. So it's still going to be a challenge, but something is actually being worked on. Now, the 1/3 rule. Now, I know it is difficult to move from one county to the other, but it is not that it cannot be done. It is just that one county feels that they are going to lose a health worker, so how do they actually get compensated or to get the other worker? So I know there is, through the intergovernmental relations, there is that provision for you to move from county X to county Y. But Dr. Soti can tell you more about that. Now, the issue about ghost workers, I think the question is that what can we do? The answer is that there's nothing we can do. We are giving you information, and we are telling you that you have 10,000 workers at a cost of 200 million. So can you do something about it? You get my point? But as a donor, as a development partner, we cannot come to your county and force you. So it is now the will and commitment of that respective government, of that respective county to be able to make... and what you'd find is that it becomes difficult because some of them, they are the ones who have put those people there. So when you are now coming to tell them to remove, then it changes the political dimension. So as a partner, what we can do is we can come and tell you, for your county, you have 5,000 workers and you are paying 9,000. So these 4,000 are here. When it comes to the decision, as per constitution now, you make your decision. Now, specialization, I think it's something that we need to look, and I'm happy the KMTC has actually brought what they're doing. But I would like to be honest here. There's something happening at our KMTCs that we need to work on. I've gone to several KMTCs. We actually sponsor the Afya Elimu students, and we normally go around to see exactly what they're doing, how they're being trained. But there's something that it's just not working right at KMTC. The KMTC we have now is not what we used to have. I went to one of the KMTCs and the students could not even communicate in English. And I thought that it was in the course so they could communicate in Kiswahili. They were not also communicating. Now, this is actually the medium of instruction. So what happens is that when we produce such kids, then they are not market ready. So there's something that we need to do to re-engineer the specific courses. I'm not saying that everybody is bad, but that was not it. In fact, I was shocked that even the lecturer who accompanied the students could also not communicate. I don't know whether you have seen this or it's only me. Now, let's start with the lecturer. The lecturer cannot communicate with the student. The student cannot communicate. Now, how will the student now communicate with the patient? So I think we need to look at our, I don't know where we went wrong, but what I can tell you, when I was growing up, when you heard that a student has come from a KMTC, it doesn't matter which KMTC, in the 80s, early 80s, now, and that's why we are talking about this market ready. You have a product that even after production, you still have to do a few things here and there to make them ready. Now, we are working with several MTCs to be able to enhance skills, competencies, and all that. But my point is, let's do something for us to be able to have the quality. I'm not saying that KMTC is bad, but I'm saying let's do something. And the same thing goes to our universities. I'm a country director. I employ staff. But I'm telling you, there are students who finish their master's, PhD, they cannot write an application letter. So it is something that is cutting across. Now we are going to competency where kids are going to be sweeping in the markets. I don't know what's going to happen. But there's just something that we need to see how to work on in terms of the quality of our education. Now, those days when you had somebody from a university, that was a university. But nowadays we meet here, it's a challenge. Yeah, with the KMTC, it's glad you have actually brought the issue of the training. We are actually partnering with you to scale up the CHIUS training, which I think is going to be very, very instrumental in the. Now, somebody asked about task shifting. We know what the court said about task shifting, and I don't want to get into that politics here because I just don't want to get into it. Maybe Dr. Soti can talk about it, but what I know, what I know is that nurses have actually been trying their best because of the workload, because of the passion that they have got to the patient, but we also have these rulings, and I would say I'm not very competent to talk about that. So maybe you can add something. Yeah, some of those are too hot for me. The government has
Dr. Soti is already saying he's not a politician, but try.
As controversial as the situation is, shortage of staff, this is always number one as a challenge. True or false? But is it number one challenge in the facilities? If you think critically, there are studies that have been done as recent as last year, and they looked at each facility and showed the number of clients they see, and then mapped those clients per health worker, per day. And you'll be surprised that majority are seeing about 5 to 10 in a day. Is that heavy workload? Well, if we say there's serious shortage of staff, you know, I've also worked from a very remote area where staffing was a big problem. At one time, Clinton, I think there's somebody here who told me I left her somewhere in that Clinton Health Foundation, yes. And when we used to have one staff per facility, so when we call them for a meeting, that facility is closed. If they are not closed, then you have a sweeper taking care of patients. Then we said, okay, let's improve this and have 2 per facility. We got support from Clinton Foundation. We brought them in. That did not improve the presence of staff in those facilities. The work area remained the same, so they had one desk, so they are working in shifts. One comes, one is away for a week, because they know they are working in a very remote area. This is not theory. These are facts. Then we said, I think at national level, policy level, let's have task shifting. Task shifting worked very well in HIV. Didn't it work? It worked very well, because at one time it was like, it's only a doctor who can prescribe ARVs. It's only a doctor who can see HIV patients. They were overwhelmed. They couldn't do it. It went down up to the nurse level to be able to do that. They did, and they worked very well. We said task shifting is overburdening another cadre. Yes? Let's call it, baptize it, a name called task sharing, so that you share your task and also supervise what is happening. In this task sharing, back policy, it has now been taken to court and it is stopped. But even before it went to court, I observed again that as much as we say we have heavy responsibility and overloaded with work, when we ask you to shed some of that to somebody else to do it, it is not working again. Somebody doesn't like it. Even before the court came, I observed that when we said integrated community malaria management to be in place, you would give the diagnostic to the facility and also give medicine, and then we are saying train the CHVs to be able to do test. It would be possible to see what it is, and we actually found they could test even using electronic gadgets. Yes? And know this is positive, and then if it is positive, this age, give it this. But again, our staff in the facilities didn't like it. Then I wondered, so why are we complaining of the workload? At the same time, we don't want to give to others to support us. So we are very difficult to manage ourselves, the health workers. Very difficult to manage. We complain, but we don't want to give it to somebody to help us. So unless we look at it from another angle, we'll continue giving number one, staff shortage, as a very severe or a very big challenge, yet in reality, it's not a very big challenge. Yes, I've also, we also had Dr. Wasuna talk about the resources that are given in facilities or money collected in facilities taken to the central revenue fund in the county, and then it doesn't come back, isn't it? And that is the reason why we have a problem now, even with the Linda Mama. And that's the reason why we have a problem with public health facilities complaining that private sector is being paid more than, that is your leaders at county level, the CECs, you know, the chief officers, they're complaining they don't see the money coming to their facilities, but it's going to private. Why? It's because our public health facilities staff have no motivation to collect that money. A woman comes, she's pregnant, you just do as usual. And nothing else in terms of registration, nothing else in terms of follow-up, nothing else in encouraging that mother to come and have a delivery in that facility. Why? Because they don't see where that money goes. Even the one that they collect doesn't come back. So they're not bothered. So it's because we are not making sure that that money at the end of the day comes and the staff feel that they have a role or a point in having that money collected. And for that matter, I think it has now been, I think you showed it there, that there's a bill coming up on ring fencing the money for health, so that we have no problem it going to the county revenue or whatever fund, but it has to be ring fenced to come back to do the health work. You don't collect money in the health facilities and take it to the road or take it somewhere else. In the same manner as we think forward, going forward with UHC, if we make insurance and have at least 80% of us insured and everybody is working and to get that money, we are going to cap how much money, if you make a profit, how much profit can go outside the health sector. So that if we have a saving, that saving goes back to health. It doesn't go to other sectors. That way we can improve health. If we don't improve it that way, then you can be making profit in health and do hotelier industry and do other infrastructure that are not necessarily related to health. So definitely there's a lot of work to do, but we have to be advocates, first of all, understand what the system requires, and advocate for the best possible ways to do this. I think the other bit I wanted to add is on the inter-county transfer. This again, an emotive issue, and is something that's being looked into, and I'm sure even the Health Act 2017 as a line somewhere. That's why we have in place the Human Resources Human Resource for Health Advisory Council. That is also going, it's just being started now as we implement the act, so that they're able to coordinate the issues about inter-county transfers, and that I hope will be able to improve those services. I think that's what I can say for the time being on that matter. Of course, informing you that technology is coming, and with technology you can talk about the policies and put it aside, but with technology a lot of task shifting and sharing is going on, upende usipende, because there's no way you are going to stop people who are chronically ill and have already had gadgets in their households to take blood pressures and to know what is supposed to be, to take their blood sugars and to give themselves injections. That's already ongoing. You won't stop it. So let's be smart and look into ways of improving, understanding, and doing quality work, rather than saying, you can't do it, I'm the one who is in charge. You'll be in charge in the facility, but out of that facility, a lot of things are going on. But again, we are the same people who are training them. When you are given some small stipend, you go and train everything, and then you don't want them to operate what you have trained. I leave it at that.
There's one question that I've often been confronted, and this is, we are talking at a very high level. We are talking of a CEC who is struggling to see where the money is coming from for health. And this is actually when it comes to the annual work planning exercise by the governors. And I want you to be good ambassadors. If you are in health, don't think of going to get money from the market. You are the ones you get, those people who come to the market at 4 in the evening. Strengthen your systems in insurance. The National Hospital Insurance Fund. invest and pay those people who are, and it is as simple as filing the claim forms. That is one. Two is following up with the NHIF. Three, ring fence that money. Four, plan for that money for utilization within the facility. Don't look far. And that's where the private sector beats us. Because you go to a private sector, the first thing they do you have an HIF? Fill it. And as soon as it is filled, somebody is working with it. Now for us, you know, that is where money is. And if you are talking about Linda Mama, UHC, that's where money is. Don't go very far. Number two, we are currently developing the next strategy, human resource. And we didn't bring it up in the discussions here. Be prepared for contracts, as opposed to sitting there permanent and pensionable. I know it is controversial, but look at it positively in that when you actually engage in a contract, you can negotiate your terms. So the issue about contracting is actually coming up, and it's something that is going to be performance-based. And like Dr. Soti was saying, how much work have you done for the day? If you have worked for that much, you get something. If you have gone over and above, you are paid for that. Now that is not in the present permanent and pensionable, where somebody gets working with a specific county and you know you are there for life. And then lastly, I know many of you have had complaints in terms of trainings. Also know that there are considerations to be able to offer all the health workforce equivalent of the AFIA Elimu Fund in terms of a loan. So you can actually get that loan at 4% interest instead of waiting forever for the government to give everybody money for training. So those are some of the issues that are coming up that we need to look into. And also the issue about technology. Now those of you who are here and are illiterate in digital world, know that the future for you is not very good. So get into the digital world, get into telemedicine and all that. That's where the future is. Thank you.